I'll be talking about this topic. Stroke volume variation is superior to velocity time integral variability. So this topic was given to me as a debate in national conference in Hyderabad 2020, Criticare 2020 on 29th Feb 2020. So my opponent was Dr. Vivek, whom I had never met before. So I only met him few minutes prior to the debate. So that was, I thought, was very interesting because generally we would know our opponent, but in this particular case, I didn't knew what was my opponent's strength and how did he look or who he was. So I think that I found it interesting in this debate. But nevertheless, I think this debate went on reasonably well. So the way I took on this debate was basically the first part of my talk is to explain as to what we understand by stroke volume variation and whether stroke volume variation is comparable to LVOT VTI as a science. And the third thing is the limitations of LVOT VTI. So these are the three components of my talk. So first, to understand the science of stroke volume variation, I think what we need to understand is in a spontaneously breathing patient, during inspiration, the blood pressure comes down, and during expiration, the blood pressure goes up. So this is a normal patient who is breathing. So this is the respiratory variations to the blood pressure, and we call it as a pulsus paradoxus. And when there is a increase in this phenomena, then it tells us that there is a volume deficit. So the opposite of this is what happens in mechanically ventilated patients, where during inspiration the blood pressure goes up and expiration the blood pressure comes down. Okay, so this is the reverse pulsus paradoxes what we see during mechanically ventilated patients. So as you see, the stroke volume variation during inspiration in mechanically ventilated patients, the blood pressure goes up, and during expiration, the blood pressure comes down. So quantifying this variability of the changes in blood pressure during inspiration and expiration constitutes stroke volume variation. Okay. So simply put, stroke volume variation is maximum stroke volume minus minimum stroke volume divided by mean stroke volume. So here inspiration, what, how much it peaks and how much it comes down during expiration. We take a difference divided by mean. So that gives a stroke volume variation. So when you look at the monitor where you are monitoring stroke volume, so obviously it gives cardiac output as well. So here you have a patient where blood pressure and cardiac output is low. So here you see cardiac output is 3.4 liters per minute and stroke volume variation is 18%. Okay. So here you give the patient a fluid allocate or a blood transfusion, PRBC with fluid allocate. So you would track on the monitor the stroke volume variation has come down from 18 to 9% and cardiac output from 3.4 is gone up to 4.5 liters per minute. So what it really tells you is because there is a variation of 18% which is taken as an index, so this patient is fluid responsive where you have given fluid and you see what has happened to the stroke volume variation as a response to the fluid given. SVV stroke volume variation is come down and concomitantly there has been an increase in the cardiac output. So this is how we interpret the trends in hemodynamic status and ascertain whether he is fluid responsive or not. So this is the science of stroke volume variation. So along in stroke volume variation, I think another science that one needs to understand is the systolic pressure variation. So what we understand is this systolic pressure variation, you look at the delta down and delta up of the curves. So in the arterial line trace, so the delta down is apneic baseline minus systolic blood pressure and delta up is maximum systolic blood pressure minus apneic baseline. So and systolic pressure variation you add in delta down and delta up. Okay, so simply if you see this curve, so this is the systolic pressure variation where delta up you take it. So delta up as you see is a maximum systolic blood pressure minus apneic baseline. So maximum systolic blood pressure minus apneic baseline. And this is the delta down, which is apneic baseline minus apneic baseline is here minus minimum blood pressure. So delta up plus delta down gives you systolic pressure variation, which also becomes a important surrogate of determining stroke volume variation. So, and what are the tools that we utilize to measure the stroke volume variation? You can, in clinical practice, you can incorporate any of these tools. You can use PICO, you can use LITCO, or you can use Vigilio, or you can use FlowTrack. So, I think in our practice, in our hospital, we use Vigilio as a tool to monitor stroke volume variation. So, what I need to emphasize is the LVOT VTI, which we measure with an echo by placing the sample proximal to LVOT opening and taking a pulse wave Doppler. So, and then tracing the pulse wave Doppler and determining left ventricular outflow tract velocity time integral. So, my submission is LVOT velocity time integral, which you calculate by tracing this curve, by placing the sample proximal to the LVOT, is only a component of stroke volume. But in stroke volume variation, we are looking at the whole stroke volume, which is varying with respiratory breaths, vis-a-vis a component, only one of the components of stroke volume. The reason I say that is stroke volume is LVOT velocity time integral into LVOT cross sectional area, which means you are leaving out the whole LVOT cross sectional area, which also has a bearing on the stroke volume. So we are only taking one part of it and trying to say this is better than stroke volume variation. So my submission is stroke volume is a better index than only taking a component of it as a representation of fluid responsiveness. So that would be one of my argument. The reason is if you leave out LVOT cross sectional area, there may be a lot of pathological conditions which has a bearing on this cross sectional area, which has a influence or which has a bearing on the stroke volume that we measure. So I think that I believe is a very important fallacy, because LVOT VTI is only one component of stroke volume and not and it's not a complete indicator of stroke volume. And as we understand, stroke volume is also one of the component of cardiac output. The stroke volume into heart rate is what we need to take. That's why all our dynamic fluid responsiveness, the key gold standard would be the cardiac output measurement, because that takes in all the components that are needed to ascertain whether a patient is fluid responsive or not. So that would be one of my strongest points to say that stroke volume is always a better indicator. Cardiac output may be a better indicator than stroke volume, and LVOT VTI comes down in the list for me. Okay, so let's look into the studies to see head-to-head studies of which have compared the stroke volume variation done by these cardiac output monitors in comparison with the LVOT VTI or stroke volume determined by echo. So this was a study that came from the French group in 2009. So as you see, they have looked at the stroke volume variation measured by FlowTrack, which is a cardiac output monitor, and compared with the stroke volume variation measured by the echo Doppler. And they found that they had a good concordance in responders, and they had a good concordance even in non-responders, which means, as you see, both were statistically significant and they remained concordant in responders and non-responders. They didn't move in opposite direction. So this was another study which came from Israel group. This study was done in 20 patients, comparison of stroke volume and stroke volume variation measured by axillary artery pulse contour method, which is a cardiac output tool, and by Doppler echocardiography. And they took 114 measurements. So they compared PICO readings versus echo Doppler, and they had a good correlation for mean stroke volume. R is equal to 0.885, which is a good correlation. And minimum stroke volume also they had a good correlation, and for maximum stroke volume also they had a good correlation. So the conclusions the authors made was stroke volume variation measured by pulse contour analysis in this study had a good correlation to stroke volume measured by aortic Doppler echo as well. So which means they were concordant and one was not superior to another. So this was a third study again from the French group which came in 2008. So where they compared stroke volume variation by echo with stroke volume variation by Vigilio. And they saw that sensitivity and specificity of both these tools were very similar and were very good. So, and there was no, as you see, area under curve is very good. So which means both performed very similarly and there was no superiority of one over another. Okay, so these are the three studies which tell us that SVV measured by cardiac output tool is as good as whatever stroke volume. So these studies have said comparing stroke volume measured by echo, which means they have taken LVOT, VTI and cross-sectional area. There is no study which has compared stroke volume variation with LVOT, VTI, which is only one component of stroke volume. So this is my argument that it cannot be superior to stroke volume variation measured by, either you have to measure stroke volume by echo. So taking only LVOT, VTI may not necessarily we can say that it is superior to SVV measured by cardiac output monitor. And what are the limitations of LVOT, VTI? So when we measure LVOT, VTI, so when there is LVOT obstruction, obviously the measurements that you would take would be very erroneous. And if there is a gradient, see, we don't measure the gradient present between LVOT, iota and the LV. So once we do not measure the gradient, we ignore the gradient. So any gradient has a bearing on the measurements we take. And this gradient can be significant in severe hypovolemia. In severe hypovolemia, when there is a gradient between the LVOT, I think that falsely represents the LVOT VTI. And when there is aortic regurgitation, seldom when we are doing this LVOT VTI as a test to look for volume responsiveness, we may not put color to see if there is aortic regurgitant jet. So if there is even a small aortic regurgitant jet or a significant aortic regurgitation, it overestimates LVOT VTI. So if there is in the presence of aortic regurgitation, if LVOT VTI is less, it means the patient is very dysfunctional. So because it overestimates, as it is, it overestimates. So if it is already low, it means that LV function can be very poor or there can be severe hemodynamic compromise. Okay. And if there is septal LV hypertrophy, so if there is a septal hypertrophy, there is a compensatory hyperdynamic changes that happen in the basal segments of the cardia. This also is known to falsely interpret or falsely indicate your LVOT VTI. So these are mainly any aortic pathologies. If you have a gradient, if you have a LVOT obstruction, or if you have an aortic regurgitation or septal hypertrophy, any of these which affects your LV outflow tract, all these have a bearing on the measurements you take of LVOT VTI, and you may be falsely interpreting the measurements. I think these are some of the important limitations of LVOT VTI. So what are the other limitations? So when there is a sudden and rapid change in hemodynamic status, which typically we see in IC, which means to say if you are looking like in my unit, if I have 20 patients in my unit, so suddenly a rapid changes happens in hemodynamic status of one patient. So I need to be rushing to that patient to perform an echo to ascertain if they are fluid responsive. So rather I would be better off having a continuous cardiac output monitor which picks up minute to minute trends, because then moving the echo machine and doing LVOT can be time consuming and it can be cumbersome. It takes at least, I would say, 5 to 7 minutes for you to get the trace and do the VTI variability. And there is lot of inter-observer variability, which is a big problem, because I have seen in my own practice where one does, and if you get a LVOT VTI may come more than say 12%, then they are fluid responsive. And I do it again, if it comes as 9%, then they are not fluid responsive. So it's a small change in percentage which can mean between harming the patient or benefiting the patients, more so when the measurements are not taken accurately. Because if you are tracing the curve in a little erratic way, or if you have not placed the sample in a very appropriate position, the readings can be misinterpreted and we can cause harm to the patient. And if your patient has arrhythmias, which commonly our ICU patients tend to have, there can be errors in measurement. If patient has atrial fibrillation, LVOT VTI has to be averaged to 5 cardiac cycles to determine what exact, which means you need to take LVOT VTI across 5 cardiac cycles and average to determine what is the right LVOT, which can be a problematic. And I think, friends, all of you understand in ICU, patient's position is a huge problem. So if you have a patient with, who is prone, you cannot do LVOT VTI. Or if you have a patient with a huge surgery with multiple drains, I think you can have a lot of problems in doing an echo assessment and determining LVOTI. Or if you have, typically many of our ICU patients have lung pathology. If you have a COPD patient, air is very bad. Air is very bad for measuring or getting a good window. So I think these are the patients where we have problems in ascertaining LVOT VTI, because COPD patients we may not get a good window, or a trauma patients where position can be an issue, and effects of mechanical ventilation and heart plane motion during measurements also can be. So if there is movements during measurements, I think that also can be falsely interpreted. I think suboptimal ultrasound window with a poor image quality can be a problem, because I'm sure all of you agree there are certain instances no matter what you do you won't get a window, and you may just not be able to do LVOT. Or if you have a patient with a huge ascites and with emphysema or any of these conditions, it is very difficult to get a good window. And these are some of the problems or fallacies where we may not be able to ascertain the volume status. And another important thing is Doppler angle error. So because absolutely that sample has to be placed in line with that LVOT opening. So if there is some difference in the angulation of the sample, the measurements that we may be taking not necessarily may be reflective of the true LVOT VTI. So these are all some of the fallacies. And typically our ICU patients are like this, who are on dialysis, who are on ECMO, or who are on multiple infusion. And to top it, if you are prone, just imagine moving your echo machine amidst all these machines and trying to keep on repeating your echo assessment to see whether this patient is fluid. It becomes horrendously difficult. I think that is a very important limitations. And this is an intermittent assessment. Unlike my cardiac output, which gives you continuous stroke volume variation, and even a nurse can come to me and said, and if I leave the instructions, if SVV is more than 18%, you come and let me know. I think a simple bedside nurse can act upon it and say, sir, now SVV is 20%, so I think we should give fluids. So I can give fluids. Unlike this, where nurse will come and let me know when it is too late, when hypotension has set in, and then you are assessing. I think that also there is a lot of time lag between the assessment and the intervention. I think all this becomes a problem. And for me, the biggest fear in ICU is by repeatedly moving your machine across multiple patients and touching the patients with the echo probe, with all your hands and sleeves dangling, with the echo cord dangling. I think you are really threatening the patient with all these dangerous infective bugs, pseudomonas, staphylococcus, enterobacters, and enterococci. So these are all the bugs which can threaten the patient, because you're constantly touching the patient. And to be very honest, when I use the echo, I only sanitize the probe. But what about all the cord and all your clothes touching the patient, and then you move on? And mind you, these patients are very sick where you are doing advanced hemodynamic assessment, and these patients are very vulnerable for infections. And you start doing echo by moving this machine from one patient to another without properly. Tell me, for sure, I think the conviction is not all of you would be taking all the precautions, aseptic precautions, when you're doing echo assessment. So I think this is the biggest threat in the face of India being at the forefront of drug resistant organisms. So I would be very worried about touching the patient multiple times with those echo machines which are not sanitized properly, which can be a huge risk for causing infections. So my take home message is, even if you look at the advanced hemodynamic algorithms of fluid responsiveness, so this algorithm is from the Tibol group in one of the review articles, there is absolutely no mention of LVOT VTI as a tool to assess fluid responsiveness. Rather, they say cardiac output is the way. So if you look at this algorithm, you would see whether patient is preload responsive, and then the second thing you would look is whether patient is spontaneously breathing, whether he has cardiac arrhythmias, or whether he has ARDS with low tidal volume. If the answer is yes, if patient is spontaneously breathing, if he has cardiac arrhythmias, then you would go for passive leg raising test, and passive leg raising test is validated to cardiac output, right? And or you do end expiratory occlusive test and look at the change in the cardiac output, or mini fluid challenge and look at the change of cardiac output by 10%. Or if patient is not spontaneously breathing, then you would look at, as per the guideline that comes from the French group, so you look at pulse pressure or stroke volume variation if patient is intubated without cardiac arrhythmias with reasonable tidal volumes. Or if this is not possible, you can look at respiratory variation of IBC. Or you can look at passive leg raising test and look at the change in cardiac output or LVOT. Usually the recommendation is to look at change in the cardiac output and end expiratory occlusive test and or mini fluid challenge. So even the algorithms don't mention about LVOT VTI as the option of choice. So which means to say there is an underemphasis. LVOT VTI may be good initially, but for subsequent fine tuning. And another important fallacy of LVOT VTI is if you look at all the recent texts that have come, see, when you do end expiratory occlusive test, the cardiac output change we are looking at is 5%. So, which means it's a small percentage change in cardiac output we are seeing. And this has to be captured by monitors which are sensitive. And I think a continuous hemodynamic monitor of these natures have better ability to pick up these changes than manually doing this LVOT, even a small errors in your measurement. So I think leads to misinterpretation. I think that is the problem which I would subscribe to when you are using these probes intermittently. So I think that would be my submission, that the small changes in cardiac output has to be picked up to determine in this day and age whether they are fluid responsive or not. Even mini fluid challenge, you give only a small fluid 250 ml and look for change in 10%. So that 10% change has to be picked up accurately, and I believe these advanced monitors have ability to pick up that small change rather than doing an echo and trying to accurately place your sample and getting the good trace and then measuring it accurately and then making a interpretation and taking action. I think it appears superfluous for me, in especially where subtle changes has to be made to achieve better outcomes. So I would end my presentation with a slide. Those who cannot change their minds cannot change anything. So that was my argument against Dr. Vivek, who spoke in favor of echo. But I think to the interest of the audience, I think what we both agreed was, which I also said, see, we do echo in our ICU for all the hemodynamically unstable patients. I think these both are not mutually exclusive. I think both have to be looked at as mutually inclusive and adjuncts to each other. I think initially when patient is hemodynamic unstable, obviously you don't go ahead and put a advanced hemodynamic monitoring. What we do is we do a echo assessment. I think echo assessment comes in the top of your hemodynamic assessment. As soon as unstable, you look at echo, look at the LV function, look at how the contractility is, and then you make some assessment in echo. Then you optimize hemodynamic. But for the ongoing hemodynamic instability, it becomes humanly impossible for you to keep doing an echo assessment, especially in patients like in our practice, for all the complicated liver transplant patients or any major hemodynamic long-standing ARDS patients. So where they continue to be hemodynamically unstable and where we need continuous assessment or continuous tracking of the trends. So that's where there is a huge value for this advanced hemodynamic monitoring to look at stroke volume variation. So we both shook our hands and we said both are indispensable. So we need to have a good clarity of understanding of both echo assessment and about stroke volume. Both have limitations. Echo has limitations, so is the stroke volume, because in stroke volume variations, the limitations, as my opponent would have said, was you should have ideal lung conditions. If your compliance is low, if you have valvular abnormalities, arrhythmias, or low tidal volumes, all this can make it difficult, or it's not very good in spontaneously breathing. So both have role, both are adjuncts to each other, and they have to be looked in unison is what we both agreed upon. So thank you very much. You can visit my website www.drpradeeprangappa.com to rehear to this lecture to gain clarity and insights. Thank you.